Okay, we're back for the last auditory learner study guide for DH 400 Cardiology. This is going to be for the final. There's going to be a couple lecture slides. The first one is going to be caries risk and reduction. The second one's going to be radiographic assessment. The third one's going to be Cambra. And the last one's going to be caries testing. All right, so let's get straight into this. Let's talk about caries risk and reduction. And when we're talking about reduction of caries, we want to know that acidulated phosphate is the best, but it etches restorations. Sodium fluoride is basically your next best option. And if you're using chlorhexidine, you do it for 1 week every month if you're a high risk bacterial consideration. The next thing we want to know is for low risk patients, bite wings should be done every 24 to 36 months, along with sealants, fluoride education, and oral hygiene habits. For patients that are moderate risk, it's bite wings every 18 to 24 months, with fluoride treatment 2 to 3 times at each recare appointment. And focus on remineralization of non-prescription fluorides at home, along with sealants if possible. Then we want to talk about the high-risk patients, which is they should be getting bite wings every 6 to 18 months with a prescription for fluoride and also at-home trace. They should also be using antimicrobial rinses, and they probably should also get bacterial testing, like a caries activity test. When it comes to diet, we want to know that there is a study from Vip Holmes in 1945, Swedish guy or Swedish study that was the first to explain the reason for the presence of smooth surface caries. Then when we're talking about saliva, we want to think about the Newburn 1962 study that showed evidence of an inverse relationship with salivary flow rate and caries. When we think salivary flow rate, we want to think of buffering capacity for the caries. More on saliva. Saliva maintains a constant pH by 2 systems: the carbonic acid, which is the bicarbonate, and then the phosphate. That's all there was on that slide, just bicarbonate and phosphate. Antibacterial factors within saliva, there are 3. The first one is lysozyme, which damages bacterial cell wall; lactoperoxidase, which is an antibacterial system; and then immunoglobulins, which have specific antibodies. Those are the 3 antibacterial factors for saliva. Things that cause xerostomia are Sjogren's syndrome, blockage of ducts, radiation therapy, meds, stress, depression, smoking, etc. Acidogenic bacteria is the primary bacteria in biofilm, which adhere to receptors on the pellicle of the tooth surface. Secondary bacteria biofilm formers adhere to neighboring organisms. That's how it was stated in the slides. Evidence of germ-free animals did not develop caries on high cariogenic food diets unless it was established in their mouths. Not sure what that means. Evidence of germ-free animals did not develop caries on high cariogenic foods unless there was some bacteria established in their mouths. Okay. Some things we need to know are MI paste, such as CPP, ACP, casein phosphopeptide, and amorphous calcium phosphate. These things inhibit bacterial adhesion and oral biofilm formation. Know that the MI paste plus has fluoride. CPP attaches to the pellicle and limits bacterial adhesion by competing with calcium for plaque calcium binding sites. When it comes to pit and fissure caries, the most common due to retention organisms, we want to think about Streptococcus mutans, sanguinis, and lactobacilli. Smooth surface caries were tested in animal models with Streptococcus mutans. When we talk about root surface caries, sometimes they're also called cementum, cervical, or radicular caries. They start near the CEJ, and they I believe they grow in a lateral direction. For these root surface caries, though, there's three main bacteria for root surface caries. It's Actinomyces viscus, which is an anaerobic facultative bacteria. There's Actinomyces naeslundii, which is a filamentous and a rods-like bacteria. And then obviously Streptococcus mutans. Then when we think about the deep dentin caries, which are close to the pulp, those are gram-positive filamentous rods and lactobacilli. Now, when we talk about lactobacilli, the minor fraction of biofilm flora and low affinity to tooth surfaces. So lactobacilli is a minor fraction of biofilm flora and has low affinity to tooth surfaces. But there are three different types of bacteria that when they come together, they produce what's called rapid synergism. That's Streptococcus mutans plus Actinomyces viscus plus Actinomyces naeslundii. And all three of these cause caries rapidly than any three alone. S mutans, A viscus, A naeslundii. All right. So that was the end of that lecture. We're going to move on to the radiographic assessment lecture. This one was short because it was mostly pictures of identifying X-rays. So get a good mental picture of what was shown. But there's a couple things that I pulled out of this. And those things are that the pulp creates secondary dentin in response to caries and trauma. And usually it's like when it's, a couple millimeters away from the pulp. This is why the pulp shrinks when we get older. And also, as I said earlier, root caries, they expand laterally. Now, we're going to go into the next one, which is the Cambra lecture. Probably one of the most annoying lectures here. Okay, so know your X-rays in identifying caries. Cambra. So caries are the most chronic disease of children and are curable and preventable. The main principles for Cambra are modify oral flora for favorable health, patient education, remineralization of non-cavitated lesions, minimal operative interventions. Those are the main principles for Cambra. Again, modify oral flora for a favorable health, oral health, patient education, remineralization of non-cavitated lesions, and minimal operative interventions. Treatment, as far as Cambra goes, is remineralization of early lesions because it is the most cost-effective. Also, restorative approach does not eliminate the disease itself, okay? Goals of clinical protocols. I put these on here because he said note this in class. Goals of clinical protocols are reduce acidogenic bacteria, eliminate and reduce risk factors, improve salivary function, improve repair by process of remineralization, and employ minimally invasive restorative approach. Some things we need to know about fluoride. For sodium fluoride toothpaste, it has to be 0.2%. For sodium fluoride rinse, it has to be 0.05%. And for a sodium fluoride varnish, it needs to be at 5%. Sealants should be resin-based or glass ionomer-based. Saliva test, there are two different kinds that were talked about here, mainly the CRT test and the caries screen test. CRT caries risk test and caries susceptibility test. Then there's pulp testing. So as far as responses for pulp testing, a normal pulp responds to the stimulus, and it is not exaggerated, but it does not linger. So it kind of goes away after a couple seconds. Pulpitis, you get a little bit of an exaggerated response, and it's painful. Mild pain with short duration, that's reversible. While severe pain that lingers, that's irreversible pulpitis. So those are the two differences between reversible and irreversible pulpitis, which is a type of response when you do pulp testing. Talked about the normal response. For pulpitis, If it's a mild pain with short duration, is reversible. But if the pain lingers with also an exaggerated response, then it's irreversible. Necrotic pulp, you don't feel shit. The thing's dead. Tests. Now, let's talk about tests. There's thermal testing, which is that refrigerant ethyl chloride spray. There's heat testing, where we use the gutta percha, that's root canal material, and it's placed directly on the tooth. Sometimes they used to use polishing cup as well. Then there's the electric pulp tests that produce a negative pulse of electricity. And if nothing else works, I guess you can drill on the tooth until the dentin is reached. Okay, last one here is caries testing. Whoever's listening to this, excuse me, I'm freaking tired. I've been a weird day. I can see Allison typing over here. Okay, Allison, I'm gonna keep going. Okay, here we go. So caries testing. Caries defined as carbohydrate modifiable transmissible local infection with saliva as critical regulators. That's caries defined. Defined as a carbohydrate modifiable transmissible local infection with saliva as a critical regulator. That is a mouthful. Okay, caries activity testing. Measures degree to which local environment favors probability of caries. Three main concerns with caries testing is validity, reliability, and it should be simple. Advantages: gives an initial baseline, patient compliance, preventative programs, lower healthcare costs, objectives. Okay, so types of caries tests. One caries test will be a question on the exam. All right. So here are the types of caries tests. We got the lactobacilli count, which is the Hadley test. I'm gonna pull up this thingamajig as well. So we have the lactobacilli count test. That's the Hadley test. High number of organisms could mean higher caries rate. Reflects caries status, common in lab research, not in private practice. Test is not suitable for dental settings. So the Hadley test is not suitable for dental settings. Then we got the modified Snyder test by Alban. Alban, this modified Snyder test by Alban is unstimulated saliva collected. Snyder test agar, focus of lactobacillus species, uses a color scale. So modified Snyder test by Alban uses a color scale. Blue, green, yellow, going from less acidic to more acidic. So the yellower it is, the more acidic it is. No color change means no susceptibility. Complete color change, high. Okay. Then we have the CRT bacteria test, which is count of mutant streptococci and lactobacilli in saliva and plaque. Patient chews paraffin pellet, and then saliva is collected. Easy way to remember CRT test. C stands for count and colonies. Okay. So CRT test, mutant streptococci, lactobacilli in saliva and plaque. Place it in an incubator for 48 hours with the paraffin pellet. Okay, so that's that. Then we have caries screen susceptibility test we talked about earlier. And this reacts in the presence of adenosine triphosphate, ATP, which is the energy source produced by our mitochondria. Okay, so for the caries screen susceptibility test, saliva swab placed into device with an added reagent. Correlates with CRT test with 75% accuracy. Plaque, pH measurements. Measure pH after food intake. pH is lower in those with caries. Lower. With caries activity. Interesting. I thought that it would be higher. But it's lower with caries activity. Okay. And then there's a caries testing device, which is called the Diagnodent. It's a non-invasive laser, uses reflection for fluorescent light. And what do the numbers mean? 0 to 10 is a healthy tooth. 11 to 20, the outer half of the enamel has caries. And 21 to 30, the inner half of enamel has caries. And then plus 30, the dentin, it's already deep. Lastly, there are caries detector agents like stains. May stain non-infected structures. not clear, may lead to excess removal of dental structures. Okay, so here we go. Let's finish this up here. Caries detecting agents. Oh, yeah, the disclosing agents for caries. Yeah, we talked about that. Yeah, it stains non-remineralizable caries dentin. It may stain non-infected structures. Not clear if it stains an organic matrix of less mineralized dentin. May lead to excess removal of dental structures. But yeah, that's a caries detector dye thing. So yeah, we pretty much covered that. Diagonal dent, 0 to 10 healthy, 11 to 20 outer half, 11 20 to 30 inner half, 30 plus into the dentin. Cavo diagonal dent. Okay. I think that's pretty much it. I'm ready to go to bed. We are gonna do just fine. All right, peace out.